Hello, everyone, and welcome back to another episode of Recharging the Human Battery here on AM 950 Radio. Dr. Cinecropy is out today, so it is just me, Mandi Dickey, nurse practitioner, covering for the show today. Last week, he was here by himself. Today, I'm here by myself. And to give you a little explanation of why that is. So last week I was out because I was having a lot of symptoms. I was on an episode of somebody else's podcast recently, and we were talking about some of the misconceptions of TBI recovery. And one of the things we talked about is that people don't just get better quickly from a TBI, and it is not a linear recovery. So it is not just an uphill recovery once you have those symptoms. They can keep coming back, and you have good days and you have bad days. And last week, I was having one of those bad days. So as you may recall, we've had some advertisements recently for our launch of our new Hypercharge Health location. And that Hypercharge Health launch kind of took a lot out of me. And I was really kind of edgy, lots of headaches, and I was not able to come and do the show last week. So Dr. Cinecropy was nice enough to do it all by himself. So today I get to do it all by myself because he's out. So here we are. Last time I was here by myself, we did a little TBI takeover. So today I'm going to do that again because we got some good feedback. ABCs of concussion. Last time I was here, we did the letter A. So today we're going to do the letter B. There's a lot of topics to talk about. And again, why am I talking about all of these things? This is a recharging the human battery of the whole body. Why do I focus on the brain? Because our brain is really the big thing that charges our whole body. It runs all of us. I could argue with the cardiologists all day long because they'll say it's your heart that runs your body, but you can't do anything without your brain telling you what to do. So for those of you that might be experiencing symptoms and you don't know what they're from, or maybe you had a concussion and you still have symptoms lasting and you're not sure if they're normal or not normal, or you're a provider and you're not quite sure what you should be looking for in your patients. These are the things that we'll be talking about when we go through these different letters. I talk about it on my own podcast as well, Brain Wellness. So that's all brain all the time. Whereas these are just these little episodes that come in every once in a while when I get to do an episode by myself. So today we're going to be talking about the letter B. So things like behavior changes. I talked a little bit about that last time, but we'll go into it a little bit more. Other things like balance, what to look for in a concussion in a baby. We'll talk about brain bleeds a little bit today, some things with bruising, brain fog, that's a big one, and burnout, a little bit different than you would think of normally with burnout in healthcare, but for a different purpose for patients with concussion. So all of these things are things that we'll get into a little bit today as those letters B. Again, this is for the person that might have a concussion and have symptoms and they're not sure if they're normal or not. Or maybe you have these symptoms and you're not sure why you had them. Think back to see, is there some reason why I might be having these symptoms? And again, if you're the provider out there listening and you're not sure what to look for in those patients, maybe this is something that you might see and think, I might have seen that in one of those patients, and maybe they did have something that I need to follow up on. So when we talk about all these letters, again, I'll try to give you some advice on what to watch for, what you can do to try to get better from them, and where to go from there. So we will get into all of these when we come back from the break here on AM 950 Radio. Welcome back after the break here on AM 950 Radio, recharging the human battery. Again, Dr. Cinecropy is out today. It's just me, Mandi Dickey, with the TBI takeover. Again, ABCs of concussion. We're doing the letter B today. So the things we're going to talk about today, again, I'll start with the letter B, starting with behavior changes, the first one I want to talk about. So behavior changes, we can also call these just a bad attitude. It can sometimes be belligerence. Again, these all start with the letter B. Also, it can just be things like the agitation and aggression that I talked about in the A episode. about a month ago when I was on here with that one. So it can be something just as simple as being a little bit more agitated. It can be as big as somebody being really emotionally dysregulated. So, what is emotional dysregulation? Um, I don't know if I've talked about this on this show yet. I have my youngest son has autism, so we deal with a lot of emotional dysregulation with him, and that was actually one of the first symptoms that we dealt with his autism before we even knew he had the diagnosis. He was very emotionally dysregulated at school, would cause a lot of disruption, a lot of problems, and I'm seeing that now, and I've heard of that with some of my concussion patients before I even had my own accident. But now I feel it in myself, this emotional dysregulation where you have these sudden changes in mood and you get upset about things you shouldn't necessarily get upset about. So, sudden mood swings, again, just really wide, fluctuating mood swings. Some can say it's, this perimenopausal female that, yes, I am that as well. But I've got this TBI on top of it. So having these really wide mood swings can be really, really common in somebody after they have a concussion and or TBI, depending again on the severity of that concussion. These these mood swings can look like extreme reactions to just everyday activities, things that you would normally not respect such a large response. So angry outbursts at times when you wouldn't think you really need to get angry at different things. Sometimes it can be from things that, yeah, could be a little bit frustrating, but you get a bigger response than you think you would normally get. Think about somebody that gets road rage. Yeah, we all get a little frustrated with somebody on the road, right? Somebody does something stupid, they don't turn their blinker on, they cut you off in traffic, and then you get people that get the road rage. Well, think about that road rage person. That could be somebody that has a response like somebody that has a TBI. So they have that angry outburst, that angry response that's out of the normal expectation of the response that you would see in that situation. So those angry outbursts can happen not necessarily just with road rage, but any time in the day. You can also have sudden tears, and it doesn't have to be at a time when something actually makes you sad. So I was talking about how I was really edgy leading up to last week when I couldn't come in and do the episode. I felt like I was on the verge of tears like all week long. And anytime anybody asked me a question, it wasn't even an emotional question, but somebody would ask me a question. But I was already so edgy because my brain was so fragile at that point that if you asked me a question, I had to really kind of calm myself down to answer it, not because it was an emotional question, but just because my emotions were on edge. So those angry outbursts can happen, the sudden tears can happen. And then there's also something that we call can actually look like what we call pseudo-bulbar affect or PBA. You can have laughter or sad or crying at inappropriate times. I used to see this all the time with my patients that had a stroke when I was working in the hospital. So after a stroke, people can have this thing called pseudo-bulbar affect, where again, they have laughter at inappropriate times, tears at inappropriate times. So severe that I had patients that were at funerals and they would start laughing, or they would be at times when something was really happy and they would start crying. And it's very embarrassing when this happens for people. And it can be very isolating because when this happens, that individual that experiences these inappropriate emotions then starts to pull away. They don't want people to see them having these experiences. They don't want people to see them having these inappropriate emotions. So they start pulling away from social events. They don't go to funerals. They don't go to events with family and friends because they don't want to have this inappropriate emotional response. And they also don't know how to bring it up to their healthcare providers because they don't realize that it's something that can potentially be treated. And it can be treated with speech therapy. It can actually be treated and something that people can work on. But again, if you don't know that it's there, if you don't know that it's a thing, you don't know to ask for it. So pseudobulbar affect, PBA, you can look that up. There's a lot of information online about it. Again, we see it a lot with stroke patients. What is stroke? It's a brain injury. It's an acquired brain injury, just a different type of brain injury than a concussion. So it wasn't caused by a hit to the head. It was caused by a vascular issue inside of the brain. Again, just easily being irritated by things is really, really common in any of these. Any of these behavior changes, whether it's changes in attitude, more belligerence, these angry outbursts, sudden tears, inappropriate emotions. Any of these can cause social difficulties for the person with a concussion or TBI. And again, like with the pseudobulbar affect, it can cause people to avoid social situations and avoid being around other people, even if it's just feeling cranky all the time. There have been several times during my recovery that I have avoided social situations because I felt like I've been more cranky and I feel like I'm not really a good, positive person to be around. So at those times, I've been more isolated. And if that goes on for long periods of time, it can lead to depression. It can lead to other things that will probably come up in different letters of the alphabet, but it can cause a lot of problems for the person that's trying to recover, in addition to the person that might be the partner of the person that's trying to recover, because it will lead to some isolation for that person as well. They might not be able to go out to those social situations either because their partner's not going out. The other behavior changes that you can see is that sometimes people will interrupt others, not knowingly, but you'll be in the middle of a conversation. Some people do this all the time anyway, but in the middle of a conversation, if a thought comes up, it's almost like an ADHD type of thing that we talked about, again, back in the A's, but just interrupting because you have a thought, and if you don't bring that thought up, you might forget it. So you might interrupt others in the middle of a conversation, whereas you wouldn't normally have done that prior to the head injury, but now you're doing it because if you don't bring it up right now, you might forget about it. So you might now be that person, or the person that you're talking to might now be that person that interrupts, and they weren't that person before. The other thing that we can see with behavior changes is that the person with the concussion or TBI might now be saying things that are hurtful or inappropriate, and they don't realize that they're saying things that are hurtful or inappropriate. That's actually something that I've experienced since my accident, and even more so since hitting my head back in August when I had my second injury. That's been brought up to me several times, unfortunately, that I've said things to other people that have been hurtful, and I didn't realize that they were hurtful. I'm a bit more blunt than I used to be, and things come out, and they don't always come out the way that they should have or the way that they would have previously when I would have thought through what I've said. And I know I'm not alone in that because I've talked to other people who have had concussions and TBIs, and they've had the same experience, that all of a sudden they're saying things now that they might not have been quite so blunt, and they might not have been quite so forthright in saying things as they are now. But those things can be said, and they can be hurtful, and the person saying them, if that's not what they were like before the accident, they're not doing it on purpose. They're doing it because of the changes in their brain, and they don't really have control over it. So that's the difficult part when you're dealing with somebody that has a concussion or TBI. When those changes happen, it's often because of either structural changes or hormonal changes or electrical changes in the brain that happen during that injury, that brain does not function the same way that it did prior to the accident. So you can't say that it's the person doing it because they are now just a jerk. They're doing it because there's been a change in the brain. So if you are the person that's trying to help that person heal, or you're the caregiver for that person, try to give them some grace on it. Maybe gently bring it to their attention so that they can try to work on it. That's something that my husband and I have had conversations about, so that he can bring it to my attention and I can learn from it, because I don't want to be that person that now comes off like a jerk, but I also don't want to just continue saying things. So I want him to bring it to my attention. I'm an empath. I feel other people's feelings. So when it gets brought to my attention that I've hurt somebody, I can feel it. And I feel the same hurt that they do. So I don't want to hurt other people, and I don't realize that I'm doing it. And I know I'm not alone on that one. So that's something that's a definite thing. The struggle is real. So have some patience with people when they're in that situation, but definitely bring it up in a gentle way so that they can learn from it. Other behavior changes that we see are some personality changes. And personality changes can happen more so depending on what area of the brain was damaged. We talked about that again a little bit back in the A letter, but the frontal part of the brain is more so where our personality is. So when we have damage to the front part of the brain, that's where we see more of those personality changes. Some of those things, it might not be so much just straight up the personality changed. It might be personality characteristics. Maybe the person lacks motivation now, just getting off the couch, getting up to do things. That motivation that they used to have is gone. Maybe they become a little bit more self-centered. And again, maybe might not be so much the fact that they are so much self-centered is that they have to be self-centered because they have so many appointments and so many different things that they have to think about to try to heal, that sometimes it might seem that way, but maybe they aren't entirely. So I kind of question that one a little bit when I saw that one pop up in some of the research that I was reading. But it is a thing, so something to be aware of. They might be less aware of the needs of others, was one of the things I was reading. I know that's not the case with me, but they might be less aware of the needs of others. Again, probably because of that necessity, because they have to be aware of their own needs and what they need to do for themselves. But again, something that can be there. So if you're seeing some of these changes and it's just been since somebody had an accident or since they hit their head, give them some grace. It might be because of that injury and they might need some help. So moving on to the next topic that I want to talk about is balance. And this one is, again, another really, really big topic that I could probably talk about for a long time, but I'm going to shorten it up a little bit. Balance problems happen for multiple reasons after a concussion. One of the first ones is just inappropriate sensory input. And this, again, can happen for a variety of reasons as well. There are lots of ways that our brain gets that sensory input. So how do we get information to our brain? We have nerve fibers that come into our brain that gives us information. We have nerve fibers that go out of our brain that tells our body what to do. So any of those nerve fibers that come in could have potentially been damaged, or the message centers that connect them to the brain could have been damaged in the injury as well. Physical injuries can lead to balance disturbance. So if somebody has a fracture, if they have any kind of neuropathy or spinal injury related to the accident that caused the concussion, that can cause balance issues. Medication side effects. So we talk about medications a lot on this show too. So neither Dr. Cinecropia or I are anti-medications. We use them when we need to, but you do need to know that those medications come with side effects. So we treat medications, use medications to treat headaches, to treat pain after somebody's had a concussion or an injury that related to the concussion. If somebody has autonomic dysfunction after a concussion, if somebody has mood changes, they're on an antidepressant, any of those medications can all alter your stability. It can all change your balance. So those in itself can cause problems with your balance. If you have vision problems, we'll talk about vision problems more and how that relates down in the V letter whenever we get to that one. But when you have vision problems, that can alter your ability to see where you are, which causes you to lose your footing. It can affect your peripheral vision, which changes your ability to see where you are, which causes you to lose your footing. And if you have something called your proprioception being affected, that's another nervous system thing. Proprioception is your ability to sense where you are in space. If your proprioception is affected, that's that nervous system for processing, sending information up to your brain about where you are, where you're stepping, where you're putting your foot. If that proprioception is off, you can step in different places and your brain won't sense where you're stepping. So you can step in the wrong place and tip over and fall. All of these things can cause problems with your balance. And then there's problems inside your ear. So all of these things we don't think about causing our balance, but inside our ear, that's where we end up with vertigo. Again, a V thing, talk about later on in the alphabet, but that can cause problems with our balance as well. That's a whole nother topic just in itself, which is why today is going to be really short on that balance topic. The next bigger one I want to talk about is babies. So babies look different with their concussions. Why? Because they have to. We've always kind of talked about how babies are made of rubber. They fall, they don't always have a concussion. Which is true, but there are some circumstances in which when a baby falls, they will end up with a concussion, but that concussion might look different than it does for somebody who's older. Toddlers kind of fall into that same category as babies for the most part, especially younger toddlers, so I'll kind of lump them together, even though toddlers start with a T, but for the most part, babies is our B category. So what can cause a concussion in a baby other than just a fall when they're rubber and they're okay? A fall from more than 3 feet. A fall onto a hard surface, if they fall onto a concrete floor, for example, a fall with a fast speed. So if something happened really suddenly, really quickly, that can cause a concussion with them. The big thing with babies is prevention. Prevention is the key to most medicine as it is with babies. So prevention of concussion in babies includes things like baby proofing, going around and trying to do as much as you can to baby proof the house, whether it's your house or a guest house, your parents' house, whatever, putting baby gates up so the babies can't roll down the stairs, making sure that they can't fall off of high places. Avoid risky situations with them. So if you have to bring laundry down to the washer and dryer, which is down in the basement, don't try to carry the baby and the laundry basket at the same time. Just don't do it. Put the baby in a safe place, bring the laundry basket down, do them in a safe order. Always supervise play with the baby. Don't leave them alone and then go try to answer the phone. Nowadays, we all have phones that are cordless. Bring the phone with you. Try not to answer it when you're around the baby because then you're still going to be distracted, but at least have it there so you can have it on speaker and pay attention to the baby. Use helmets and protective gear anytime you're doing things with babies or very young toddlers. Bikes, if you're taking the baby on a bike ride with you, use those baby Bjorn things, carrying them around that way. Just anything that you can do for safety. Prevention is always going to be your best thing. And then use car seats appropriately. Make sure they're facing the right direction. Make sure they're plugged into the car correctly. Go through all those safety measures. That's going to be your best bet to try to prevent a concussion in a baby. If the unthinkable happens and the baby does get a concussion, things to watch for with them. Babies are different because they're unable to explain to us what they're feeling. They're unable to tell us that they have a headache. They're unable to tell us that their stomach hurts and they feel like they're going to throw up. So it's really, really important for the adults in the situation to monitor those babies, whether it's in a daycare setting or whether it's the parents or grandparents. You need to be able to monitor those babies and watch for symptoms, watch for changes. The kind of false information on this one is that babies will lose consciousness or they'll go to sleep and they won't wake up. Babies often don't lose consciousness. Children often don't lose consciousness. So that's not something necessarily to watch for in itself. Babies often will immediately cry because the fall is a scary thing. So they're going to cry, but the symptoms might not be present for hours. So you're going to need to watch them for an extended period of time with this. Watch for signs of behavior changes, emotional changes, physical changes, or sleep changes. So what do those things look like? Maybe the baby or the really young toddler loses interest in their toys and they don't want to play. Maybe they usually want to play, they don't want to play now. That's a change for them. Maybe they start throwing up or they have changes in eating. Maybe they're refusing to nurse or feed or drink. Maybe you can't console them. You can't calm them down when they're crying. Maybe they're off balance if they're one that's starting to walk yet. If they're not walking, maybe they're unable to move smoothly from one position to another that they used to be able to do. So if they used to be able to roll or sit up, now they can't do that quite as well. Those are things to watch for. Seizures is another one to watch for. If you've never seen a seizure in a baby, what it might look like or are repetitive motions on one side of the body, or maybe their eyes are off to one side and they're not crossing over to look around the room. Obviously, if they have blood or clear fluid coming from their ears, that should be a really big sign to you to call 911 or get emergency assistance. Other things that you might see, new toileting accidents. Again, for the really young toddler that might be potty training, maybe they're having more accidents than they used to have. Maybe they're showing signs of sensitivity to noise or lights. Again, they can't tell you this, but maybe they're covering their ears or maybe they're flinching when you turn on a light or maybe they are actually holding their head if they're able to do that to show you that something's not right. And then obviously if they have bumps, bruises, keep an eye on those too. We used to say that you don't want somebody to go to sleep if you think they had a concussion because you don't want them to potentially fall into a coma. Now we know that sleep is really, really important for the brain. So you do want the babies to try to keep on that same sleep schedule. However, if you can't wake them, that's a problem. Then you're going to need to call 911. But do try to keep them on that same sleep schedule because they need their brains to heal as well. So that's when you need to call for those things. So the big thing with babies is prevention and then monitoring so you know what to watch for so that you know when to get help with them. Again, most of these babies will heal within a regular time frame of 2 to 4 weeks. Most. Just like adults, there are the exceptions to the rule. There are severe cases that will be more detrimental, but for the most part, most babies will heal rather quickly from those. Just keep an eye on them. The next bigger topic then is brain bleed. Brain bleed can come by many other names. intracranial hematoma, subdural hematoma, epidural hematoma, lots of different names. It might be mild. It might require surgical intervention. So there's a wide variety of what happens with the brain bleed. The big thing with brain bleeds is that we need to identify what happened right away. So when somebody has a concussion, when they have a head injury, the first thing that we do, or the first thing that should be done when somebody goes to the emergency room or they go seek medical assistance, is get a head image. CT of the head, if somebody acutely had an injury, should be the first thing that happens, because you need to make sure that there's no blood on the brain. Now, that said, if somebody had an injury several weeks ago, several months ago, and we get an image, an MRI tends to be better later on, because we can actually age that blood. Blood looks different depending on how old it is on a CT or an MRI. So we can tell how old it is. We can tell kind of approximately when the injury might have happened based on how it looks on that image. So we get that image. We need to know what it looks like, where it is on the brain. Symptoms can show up immediately. They might take weeks or longer to develop, which is why I say maybe we are getting that head image weeks or months down the road, because those symptoms might not show up right away. Some of those symptoms might be a little bit more specific to a bleed than just a concussion, a headache that gets worse. So pretty much anybody that hits their head is going to have a headache. Concussion, you're going to have a headache to some degree at some point with it. How long it lasts is going to vary from person to person, depending on the severity of the concussion, depending on the severity of the symptoms. But a headache that gets worse is one that's problematic. That's when we're concerned about something bigger happening. If the person is vomiting, that's going to be a sign for us that something bigger might be happening. That's something that's definitely going to trigger me as a provider to say, I need to get an image of your brain. If there's drowsiness or a gradual loss of consciousness, again, that's a concern that something is growing on the brain, something is changing rather than just a sudden impact. If there's dizziness, confusion, again, that can be there regardless of whether there's blood or not. If there's pupils of different size, so pupils are that black part of our eyes, right? If they are different in size, that could be something compressing on the brain, causing that change in those pupil sizes. So that's something that might show us that there's something pressing on the brain, and that would be potentially blood. That would be a symptom that would tell a provider that we need to get an image of the brain. Somebody having slurred speech, again, could be with or without blood. Paralysis on one side of the body. Paralysis means that you can't move one side of your body. So that could be present again because of something pushing on the brain. Seizures are more likely to happen with blood on the brain rather than just with a concussion. I say just, but concussions are not just. But blood is very irritating to the brain. So blood can cause pain, and blood can cause seizures potentially as well. And basically with any kind of head injury, if somebody's symptoms are worsening, you need to call 911 or seek emergency assistance, because something is changing and something has gotten worse. So when those symptoms are worsening, you need to seek medical assistance with those. So what's different between a regular concussion and a concussion that causes a bleed? Some of those causes, the most common causes of bleed on the brain would be a fall, motor vehicle accidents, assaults, and a mild trauma. Even if somebody's on a blood thinner, just a very mild trauma can cause bleeding, even hitting their head on a cabinet in the kitchen. I say that because I've had patients who've had that happen. And that might be something that wouldn't really register in your mind until you develop symptoms later on. And then you come in and you get that image, and then we find blood on your brain and we ask you, have you had any injuries lately? And the only thing you can tell us is that you hit your head on a cabinet a couple of weeks ago. I say that again because I had patients that had that happen. So again, those other terms that I mentioned, the subdural hematoma, the epidural hematoma, the intracerebral hematoma, they all look a little bit different, and the causes are a little bit different. So that's the next thing I'm going to talk about as part of this. So subdural hematoma, when we talk about these different types of words, it tells us where in the brain the blood happened. So the subdural hematoma happens between the brain and the dura. They're right outside the brain. Between the brain and the skull, there are layers of protective tissue that help to cushion our brain between the brain and the skull. And the dura are those layers. So the brain and the dura, between the brain and the dura, that's where that blood happens with a subdural hematoma. So the blood is not actually in the brain itself. It's on top of the brain. It's pressing on the brain. So this is when this can be an acute injury. So if somebody falls and hits their head right now, we can end up with an acute subdural hematoma. It can be a subacute. They fell and hit their head and a couple weeks later develop symptoms. It can be a chronic subdural hematoma, meaning that person might have been on a blood thinner and maybe hit their head just a tiny little bit and months later develop symptoms, and we get that image months later and that blood is already old when we get that image. So they may or may not have a lot of symptoms left anymore. Sometimes we even find those images because of an accident. We need to look for something else. And then we find this old blood. And then we have to look back and say, what happened that might have caused that? So that's where those three different categories of that subdural hematoma come in. But basically, the big thing I want you to know on that is that the blood is not actually in the brain tissue itself. It's on the brain. It's pushing on the brain. So that blood can fairly easily be removed if it needs to be surgically removed. It doesn't always. So if it's a very mild bleed, the body can reabsorb itself. So that's why I said at the beginning of this part of the conversation that sometimes it's mild and sometimes it needs surgical intervention. So not every brain bleed is going to need surgery to get that blood removed. Sometimes it just needs time for that body to reabsorb it and it goes away. As the body reabsorbs that blood, the symptoms improve. And time again, after watching patients in the hospital and the clinic, they would improve, they would get better. And most of those patients with a bleed would get better to the point where you would never have known that they had a bleed. Whereas somebody with a stroke or somebody with a concussion that had damage to the brain tissue, those are the ones that get leftover symptoms. When you have blood on the brain that's pushing on the brain, it doesn't cause permanent damage. That gets better. It goes away. Yep. The next level down, the epidural hematoma, that's actually one level higher than the subdural. That's between the dura and the skull. So that's not closer to the brain. It's farther away from the brain. That blood can be from a ruptured blood vessel. It can be from an injury as well, too. That presses on the brain. Those are usually much more mild. Again, from a fall. We're in Minnesota. We're entering winter season. We just had our first snowfall last week. It's going to come back. Sorry to tell you folks, but it's going to come back. We're going to get more snow. We're going to have more falls. When I was working in the hospital all the time, this is probably the number one thing that I saw was these little epidural hematomas because people would fall and they would hit their head. Elderly patients would go out, try to shovel their snow on their sidewalk by themselves. They would fall. They would have these little bleeds. They would recover. So it just takes time on this one. Most of these are not surgical. The last one in this category is a little bit more problematic. It's the intracerebral hematoma. The other terms you might hear for this one is the brain bleed, the intraparenchymal hematoma, intraparenchymal hemorrhage, brain hemorrhage, lots of different terms that we use for that one. Basically, this one just is bleeding into the brain tissue itself. This one can be from an injury, so it can be from a really severe fall or a motor vehicle accident, but it can also be from a rupture of an aneurysm or a malformation, vascular malformation in the brain. So it doesn't have to be just injury related. But that one is deeper in the brain. That one's harder to remove surgically, typically, depending on the location, because I always used to say when I was working in the hospital, our brain is real estate. It's all very expensive real estate. So depending on where you need to go in there, surgery can be very problematic because you can actually cause more problems than good. So we always weigh the risks and benefits on whether or not that blood actually needs to be removed or whether we need to give people time to just let the body reabsorb it. So there's a lot of monitoring involved. And I would get lots and lots of questions from people in the hospital, their family members asking, well, why aren't you just taking them to surgery? Because sometimes we need to monitor first and make sure we're not having problems. So that's kind of the quick and dirty. I've given lots of bigger conversations, lots of bigger presentations on brain bleeds. For the purpose of this show, that's all the deeper I'm going to go into it. If you do have further questions on that particular topic, feel free to leave a comment or a question. The next real quick one I want to talk about is bruising, because this one just is a really quick one. This one can show up at the site of injury or across the site of the injury, depending on where the head injury was. When we call it a contusion. It can happen with really minor injuries. The funny thing about with bruising, it can happen whether or not you hit your head, or it can not happen whether or not you hit your head. So bruises may or may not be present. Bruises may or may not be present on the head. So when you have an injury that gives you a concussion, again, it doesn't have to be a hit to the head. Sometimes it's a hit to the chest. Sometimes it is just the force of the injury that gives you the concussion. In my car accident, I had bruises all over my body, but I didn't actually hit my head, so I had no bruises on my head. I had bruises on my knees that lasted for months. So some of those bruises will last for a very long time. It depends on the depth of the bruising that you get as well. With these bruises, you can use cold compresses with them. It's questionable whether or not you want to use ibuprofen, depending on which reference you look at. Sometimes we tell you not to use ibuprofen in those first 24 hours because we don't want the bruising to get worse. So acetaminophen usually is okay for an anti-inflammatory, kind of bring that down a little bit. And then you can potentially use ibuprofen if you're safe to with other health issues that you have beyond that to take down any swelling that's related to that bruising as well. But that can take some time. But that was another question that I had that came up with the bees. The next one, the bigger one, is brain fog that we'll talk about before we get to the break. And then the last one I'll do after the break. So brain fog. Brain fog is probably the biggest symptom seen by people with concussion and traumatic brain injury. What is brain fog? Brain fog is poor memory. It is difficulty thinking clearly. It's lack of focus, slowed thinking, difficulty learning new information. It's feeling like you're in a haze or thinking slower than normal. And I actually was reading some different references this week in preparation for this. And one of the sites said that you feel like you're thinking slower than normal because you are. And I had to laugh I actually laughed out loud when I read that one because I'm like, no wonder. It's kind of a no-brainer on that one. Yes, you are thinking normal and your brain is processing slower than normal. So yes, you're thinking slower than normal. So where does this come from? Why does brain fog happen? Really, it's triggered by anything that puts a demand on your brain, anything that puts a cognitive demand on your brain. So if you're in a noisy environment, if you're trying to read, if you're trying to use a computer, if you have children in your house, if you have a spouse, if you have a partner, if you have pets, if you are in a grocery store, if you're in any kind of shopping environment, if you are driving on the road and you have to concentrate on your driving, if you're trying to do anything, literally anything that takes cognitive effort, it can cause brain fog. If you are sitting in a restaurant and you have to think about what you're going to order off of that menu, it's putting cognitive effort. It's going to cause some brain fog. If you have a headache or any kind of pain, it can cause brain fog. So brain fog can come from so many things. It can come from everything that we do on a daily basis. And it can be very, very exhausting. And the more tired you are, the more brain fog you're going to have. So what are things that you can do to try to help it? Because you're not going to get away from it. What can you do to try to help it? Number one, get enough sleep. And I can't say that one strongly enough. Even for some people who've not had a brain injury, getting enough sleep is the number one thing that you can do for your brain health. For adults, 7 to 9 hours of sleep is what we really need. Once you've had a head injury, you probably need more than that. And it really needs to be uninterrupted sleep. That's the best thing for you. Go to sleep at the same time, wake up at the same time, get in that routine. Stay really well hydrated. Half your body weight in ounces of water. That's what you need to do. So we're in the US. I was just talking to somebody from the UK yesterday. It's different there. Half your body weight in pounds, divide that by 2. Divide your pounds by 2. That's your ounces of water you should drink every day. Eat healthy. We've talked about that a lot on this show. Take breaks before you think you need to take them. My OT tells me that all the time. Avoid alcohol. It's not good for your brain. Might be fun, but it's not good for your brain. Light exercise. We've talked about that too. So many more things that I could say, but those are kind of the big ones. We'll come back after the break and talk about burnout. Here on AM 950 Radio for Recharging the Human Battery. From our last break here at our last little segment, I am fired up today. It's usually Dr. Cinecrope that gets all this fired up. But our last topic for today, our last B letter, will take us through the rest of the segment here. Burnout. So we're talking about the ABCs of concussion. Letter B, our last topic is burnout. And this one, so we've talked about burnout, I think before on this show in terms of healthcare and how the healthcare providers get burnout and why we might get burnout. And there are so many different reasons why healthcare providers and healthcare caregivers in general get burnout because of all the work that's required to care for other people. But that said, I looked up the definition. So the true definition of burnout is an ongoing state of feeling overwhelmed, fatigued, and emotionally drained due to consistent stress. And like we always talk about, we usually talk about it in relationship to work, with healthcare especially, but we usually talk about it in relationship to work. It can be related to family situations, social situations, but it can happen in relationship to being a patient, especially within a patient when you have something like concussion or a chronic illness that requires you to go to multiple appointments all the time. I actually have a chapter in my book about this. So I did write a book about my first year of recovery because it was such a different perspective being a healthcare provider than going through this whole recovery process. So I have a chapter called The Appointment Marathon, and it's called that for a reason because it was one appointment after another. I had neurology, I had my neurooptometry, that was my eye doctor, my physical therapy, occupational therapy, speech therapy, mental health. And at one point I had not only my regular mental health appointment, but my PTSD therapy, my couples therapy, because my accident caused problems with our relationship. I had neuropsychiatry for my neuropsych testing. I had my primary care. I started neurofeedback. I was doing the photobiomodulation and transcranial laser at Hypercharge. I had all of these appointments. I had a couple chiropractic appointments. I know most people do more than just a couple appointments, but I had all of these appointments. And then I know there are other people that do even other things in addition to all of this. So I had appointment after appointment after appointment. And when you're doing all of these appointments, you feel like being a patient is your full-time job. And it basically was. I couldn't go to my full-time job. I was a patient as full-time. So you feel like being a patient is your full-time job, and it is exhausting always being a patient and having to keep your calendar organized when your brain already isn't functioning appropriately. Trying to keep anything organized is interesting, to say the least. But keeping that calendar organized, having to do all of the exercises that are prescribed by all of the therapists. So when you go to all of those therapy appointments, they give you exercises to do on a regular basis. So even outside of all those appointments, you're doing all of these exercises. And then you have to try to get in some sort of regular exercise as well on a regular basis. Never mind trying to do all the regular things like take care of your family and your home and figure out what to make for dinner and get your laundry done and try to do some sort of work if you're at that point when you're actually able to do some sort of work. You're doing all of these things on a regular basis. And burnout is real when you're going to all of these things. I actually got to a point in my recovery at some point about a year in that my neurologist asked me if I needed to take a break from my therapies because maybe I was overworking. That's a thing, to do too much. You can have too much of a good thing. And we've talked about this on the show and on other episodes of having too much of a good thing. And you can get burnout from doing too much. So as your brain is trying to heal, you're trying to relax, you're trying to rest, you have to take those breaks. I mentioned that earlier on in the one of the last ones I was talking about, the brain fog. Taking breaks, right? Taking breaks before you need them. So take those breaks, whether you are, again, the person experiencing the TBI, whether you have those symptoms, you're not sure what they're from, or you're the provider seeing these symptoms in patients. Watch for these. Try to be patient with the person that's having them. If you have other thoughts, let us know. Otherwise, until next time, be well. Take care of each other.